Good morning, everyone. Welcome to my YouTube channel, Pain Free Partha. So today we are going to talk about renal function tests. And in the next 15 to 20 minutes, I will cover some interesting topics of renal function tests. And welcome and greetings from my institute, Mahatma Gandhi Medical College and Research Institute, Pondicherry, India. So why do you want a renal function test? Whether we have a renal disease or not is number one. Whether we have given some treatment, for example, a kidney infection is there and acute kidney injury is there, we have given an antibiotic. Whether the kidneys are responding. Determining the progression of renal disease. For example, a patient's diabetic nephropathy has got a creatinine of 1.5. The next year, what is it? Stage, the level and type of renal disease. What's the type? For example, a tubular dysfunction, a glomerular dysfunction, an autoimmune disease causing glomerular problem, something like that. Can also be which function, for example, glomerular versus renal. The type of renal disease is also possible. Stage, the level. Everything is possible with the renal function test. What to collect and how? Random blood sample is sufficient. Sometimes the recent high protein ingestion may increase creatinine and urea levels. Hydration status. You should be hydrated. And that's the problem if you keep fasting. Fasting, urea may be slightly high, 0.03 or 0.05, something like that, very minimal. Because more of protein breakdown and more of urea formation. And hydration also has an effect. For example, fasting, if you take, they are dehydrated. And this may increase urea. So that is the problem with hydration. So you don't need to take fasting. You just take a normal random sample. A midstream urine is ideal. For timed urine collection, such as 24-hour urine creatinine clearance, an accurate collection over an entire period is crucial. Very difficult. 24 hours accurate is very difficult for practical purpose. So what usually done is 5 to 8 hour timed collection is what is especially outside the hospital settings. In the house you take 24-hour urine protein. How will they take? They will go to office. So that is what is the 5 to 8 hour timed collection. What is GFR, which we have already told in the previous video, is about how much ml and which the substance is plasma and filtered. Okay, plasma is filtered into the clearance of a substance from the blood. The characteristics of an now your substance. What the substance is called a marker. Now, what are the qualities of a marker which can mimic the GFR, the rate of this clearance? It should appear in the plasma at a constant rate. It should be freely filtered by the glomerulus. It should neither be absorbed nor secreted by the. It should not undergo hepatic metabolism. It should not undergo muscle metabolism. All these things are there. There are some exogenous markers for this. That is plasma inulin clearance. This is almost equal to GFR. Ioxol, so many things are there. EDTA, 51 chromium EDTA. So it is very difficult to assay this inulin. So all these exogenous markers, plasma inulin clearance, a substance is given and how much is the clearance of this equals GFR. Why? It is completely filtered, it is neither reabsorbed, there is no secretion, there is no extrarenal metabolism. Whatever comes, goes. That is why it is called inulin clearance is equated with glomerular filtration rate. But it is very difficult to assay these things. So what we do is a creatinine clearance. Creatinine is an endogenous marker. We are not giving anything. See, for example, now the creatinine clearance involves urine over 24 hours is equal to urinary creatinine, urinary volume by serum creatinine. This is simple. Urine creatinine, volume of urine by serum creatinine. So if you have this body surface area, this is basically for 1.73 square meters. Then if with the patients divided. This is creatinine clearance. There are a lot of formulas, calculate formulas. 140 minus age into mass into 0.85 female divided by 72 into serum creatinine. There are a lot of formulas for this. Simple is urinary creatinine into urinary volume by serum creatinine. Now we have already told an exogenous marker should not be secreted in the tubules, but creatinine is secreted. That is why your creatinine clearance may be slightly overestimating the original GFR. The amount of creatinine also depends upon the muscle mass. There is a difference between males and females. Lower creatinine muscle mass, lower creatinine in pregnancy because there is a lot of blood flow will increase it. Creatinine can change as much as 30% with red meat. That is a dietary factor. So all these things are possible with creatinine clearance, estimating GFR. Now, what's the normal creatinine value? That is also a creatinine value. Is adult male is around 0.6 to 1.2, female is around 0.5 to 0.75. There are small variations with this, with race, food, muscle mass, all these things. But usually we keep around 1.1. In the pediatric age group, it is 0.3, you see here. In pregnancy also, if it comes to 1, you should be careful. It is usually 0.8. Renal, when it will increase serum creatinine? Okay, it will increase to 2.2. When renal function is decreased to 50%, here only creatinine in stage 1, 2, 3, 4. This is what is normal or high. This is 60 to 80%, 80 ml per 60 to 90, 30 to 60, 15 to 30, less than 50 is stage 5. Stages of CKD is an exam question 1, 2, 3, 4, 5. But when will the creatinine increase? At this age, around 2 or 3 level. Here only the creatinine will start to rise. Here you can see the kidney size is shrunken in ultrasound to 7 centimeters or 6.5 centimeters here, to say that there is a definite loss of renal function. Creatinine values may change with the liver disease. Why? Creatinine is produced by amino acids in the liver. Rapidly changing kidney disease. It will take some time to emerge. Intense exercise. Dehydration will affect, but not much as it affects blood urea. Trimethoprim is almost these drugs are not at all used nowadays. Now, there is a lot of confusion about what is blood urea and blood urea nitrogen. Very simple. BUN is the nitrogenous component of blood urea. That is around 50%. Very simple. 46.7 you see. It is around 50%. Urea is 40. Your BUN is 20. Okay. So what is the problem is commonly used in US and Europe. That is what we follow. Urea is 15 to 40 milligrams per deciliter. Elevated levels can cause impaired kidney function, dehydration, or increased protein breakdown. I will come back again to this. Blood urea and BUN. The difference is basically 50% is the normal value, and blood urea is commonly used in Europe. Urea may increase in other conditions not related to diseases, GI bleeding, dehydration, catabolic states, maybe decreased in starvation, low protein diet. This starvation is not fasting. Fasting, it may increase. Starvation means there is chronic problem with muscle mass decrease. Serum creatinine is a more accurate, yes, very important is this. Creatinine is more accurate, but urea is earlier. Creatinine will take some time. You can see acute kidney injury, urea is 75, creatinine is 1.1. The next day, creatinine will increase to 2.2. So urea increases earlier in kidney disease. BUN to creatinine ratio. Blood urea nitrogen to creatinine ratio is prerenal, it is 20:1. So because it increases much than creatinine in prerenal disease. So the increase is much. Intrinsic renal disease, it is around 10:1. In upper GI bleed also high BUN by creatinine ratio. Okay, that is what the urea reabsorption also increases. That is why there may be an increase in BUN. In renal disease also, there is an increase in urea. That is what I told. Urea absorption increases in renal disease also because kidneys attempt to conserve water due to reduced blood flow, enhancing urea reabsorption. But this is not much affected. Creatinine is not much affected. It tells that it's an intrinsic kidney disease, but it tells little late. Now we know about blood 1, creatinine. Okay. Cystatin C is a low molecular weight protein produced by all nucleated cells and filtered by the kidney. Okay. If GFR is low, cystatin C is high. But unlike creatinine, it is reabsorbed and metabolized by proximal tubules, unaffected by age, muscle bulk, or diet. So early renal impairment, it is better. May be affected by thyroid disease, cystatin C, and smoking. Normally is around 0.6 to 1.2. So thyroid disease, you should be careful with cystatin C. Albuminuria and proteinuria. There is a lot of confusion. If there is a molecule called microalbumin, almost nil. If the albumin secretion is less, then we call it as microalbuminuria. There is no microalbumin actually. Albuminuria is used to incipient nephropathy in diabetics. We have found out even 30% have got albuminuria. Our study is published in diabetics. Albuminuria is an indicator of cardiovascular disease. It is gone. Glomerulus is gone. The endothelial permeability is gone. It is a marker of chronic renal. Normal is about 140 milligrams. Urine albumin can be measured in 24-hour creatinine, albumin by creatinine ratio. Albuminuria severe on 2 occasions indicates glomerular dysfunction. Albuminuria for 3 or more months is indicative of CKD, and 300 milligram is the cutoff. Proteinuria can come from glomerular, tubular, or overflow or urinary tract infection. Whenever we say there is a proteinuria, and we should be very careful, there is no UTI. There is UTI, all these things are gone. Glomerular, tubular, or overflow. This is what I want to tell now. Glomerular function is B, blood urea, BUN, and creatinine. Test of glomerular function and also tubular function may be urine protein. Okay, there are classifications. Greater than 300 milligram per gram means grade 3. Now, what will happen in normal? In healthy urine specimens, urine protein is negative. Bilirubin is not detected. Glucose is not detected. Okay, unless there is an infection. Blood may be present in renal tissue. If there is a blood, it may show for protein. It may show for hemoglobin. Thus, cannot differentiate urine districts. What do you mean by cast? Cast is protein plus leukocyte. There is a protein cast. If there is an epithelial cast, it means epithelial cell plus leukocyte. That is what is called a cast. If there is protein, leukocyte, and whatever it is, then it becomes the cast. Cast means we should be careful. Now we all know that there is a glomerular function test. Even urine proteinuria is a glomerular function test because excessive glomerular dysfunction can cause this. Now these are glomerular tests. What will happen to the convoluted tubules and loop of Henle, tubular tests? Now, if there is a problem in concentrating ability of the kidney, then it is a problem with this loop of Henle. Okay. So, urine osmolarity higher than implies a normal concentrating ability. There is something called water deprivation test. I am not going into the details of that. So, this is a function of tubular function, and urine osmolarity less than something like that. Okay. So, urine osmolarity is a function of tubular function. A renal tubular acidosis test, kidney's ability to excrete hydrogen ions. That's what I told, no? DCT, last video. DCT, hydrogen ion excretion, and also hormones. FENA, fractional excretion of sodium is, now you see, urinary sodium into serum creatinine, divided by serum sodium into urinary creatinine. This is fractional. If it is more than 2%, it indicates intrinsic renal disease. If it is less than 1%, it is a pre-renal cause. FENA is usually tubular necrosis and pre-renal uremia. If it is more than 2%, it is a tubular dysfunction. That's what I told. Glomerular dysfunction, kidney function test, tubular dysfunction, kidney function test. If the patient is on diuretics, the FENA may not be accurate. Electrolytes and the kidneys. Hypocalcemia can occur. The normal range of hyperphosphatemia can occur. Hyponatremia can occur. Hyperkalemia can occur. Hypermagnesemia can occur. What are the things that can happen? hyponatremia, hyperkalemia, hypermagnesemia, hyperphosphatemia, hypocalcemia. We have seen some cases of unknown case at all, comes with its diabetic patient, hypertension. Now we see there is a calcium decrease. Then we see that the patient creatinine is high. Right. CRF producing hypocalcemia, first of all manifesting as seizures due to hypocalcemia. All these things can happen. So what are the electrolyte changes? Number one, hyponatremia, hyperkalemia, hyperphosphatemia, hypermagnesemia, hypocalcemia. All these things can occur. The pH is often acidic because the hydrogen ion secretion is coming out because of the DCT. So if that is not proper, tubular function, impairing acid excretion. Okay. So acute kidney injury, the acidosis may be fast. Chronic kidney injury, usually we give oral bicarbonate and settle, and that is insidious. Already we have told about cystatin C. There are a lot of biomarkers, pseudouridine, acetyl, myoinositol, so many things. Biomarkers in kidney disease. Somebody can ask. What we need to know about NGAL. NGAL is available, urinary test is available, can be detected early before serum creatinine. So it is available in India, 8,000 rupees if you want to test urine for NGAL. It can also test, you can also test from blood. Kidney injury molecule 1, a membrane protein that is upregulated in proximal tubular cells. You can see here, if there is an early indicator of tubular damage, not glomerular, then we can see kidney injury molecule KIM1. So interleukin 1, but snake bite, it is more important. We can see IL-18, snake bite, or sometimes interleukins are increased in systemic inflammation. There are a lot of other markers. We go into cystatin C and NGAL, urinary, there are a lot of things, uromodelin, transcar protein, urinary retinol binding protein. This is very important early damage for diabetic nephropathy. They are all traditional markers of kidney dysfunction. MicroRNA, LFABP, uromodulin, transcar protein, retinol binding protein is for diabetic nephropathy. There are a lot of studies, even plain hemoglobin, if 6.5, then your kidney function is not proper. Already we have told in the last class. Imaging studies, ultrasound or CT scan. Yes, we have a stone, we have an obstruction, we have an irritable stricture. All these things can be found out by CT scans. Renal biopsy, what is the type of interstitial nephritis? Membranous, glomerulonephritis. All these things can be found out by renal biopsy. For example, tuberculosis. Techniques like renal scintigraphy can assess blood flow and renal function. Now, whether it is there or not there, functioning or not there, can be found out. These are all the other tests. Plasma renin activity, PRA, kidney-induced hypertension, we find out PRA and aldosterone levels. Parathyroid levels may be elevated in chronic kidney disease, disrupted calcium and phosphate balance. They say that the patient has got renal osteodystrophy. All these things are others. For example, hemoglobin simple, a urinary scan, imaging studies, parathyroid, PRA, so many things are other factors. Whatever it is, urine output is a useful tool for evaluating kidney function, especially in acute kidney injuries. In chronic renal failure, they may pour 1.5 liters, but it may not be creatinine, it may not be having urea, it may not filter only. So urea creatinine rises, urine output may be normal. So that is possible with CRF. But in acute kidney injury, urine output is significant monitor. So why we need? We need to know whether there is a disease. We need to know the progress. We need to know the type. Random blood collection is okay. Midstream urine collection is okay. And if you want 24 hours, preferable to 5 to 8 hours. Urea burn or slightly increased in pre-renal, but creatinine is definitely renal. So it takes 50% to go out kidney to increase in creatinine, but urea burn may increase little earlier. Electrolytes I've already told: hyponatremia, hyperkalemia, hypophosphatemia, hypermagnesemia, and hypocalcemia. Acidosis, biomarkers, and others. In biomarkers, already we are told NGAL, urinary lot of retinal binding proteins, uromodulins. So many things are there. FINA is an important of tubular dysfunction, less than 1%. Now, which is glomerular? One, urea, creatinine, or glomerular. Proteins may be either glomerular, urine proteins may be either glomerular or tubular. Tubular or other things, for example, all your pH, electrolytes. Tubular is more important. Yes, NGAL. Urine output is significant in acute kidney injury. Thank you. Visit my site www.painfreepartha.com for slides and my YouTube channel, Pain Free.